Hello everyone. Thank you for the invitation to speak today at this amazing week. I am Dr. Mohid Khan, Consultant Gastroenterology Neuroendocrine Tumours. I lead the Neuroendocrine Cancer Service in South Wales, and I'm going to tell you a story about the transformation of the South Wales Neuroendocrine Tumour Service, or Neuroendocrine Cancer Service, using patient-reported outcomes, patient experience, and co-production. Next slide, please. So, these are uncommon tumours, and some people may not have heard of them. Neuroendocrine tumours, or NETs, or neuroendocrine neoplasms, are what we call them, and they are generally slow-growing tumours. But they're more common than people think, more common than doctors think, more common than health professionals think, and there's an increasing incidence. So these are three famous people who've had neuroendocrine tumour, and I'm not going to tell you who they are, but people can put that in the chat if they want. So let's go to the next slide, please. So neuroendocrine tumours, or NETs as I'll call them, I'm not going to explain, there's not enough time to explain what they are, but on the left, you can see that they can arise, the primary site can be from different parts of the body. So you can have neuroendocrine tumours from the stomach, the pancreas, small intestine, rectum, colon, lung. And the primary can then spread to other areas, commonly liver and lung metastases. But these are heterogeneous tumours, so no one patient is the same as the other. Most commonly, they arise in the gut, so we term them gastroenteropancreatic NETs, or GEP NETs. And people can survive for quite a number of years, even with metastases. The graph there demonstrates the incidence of NETs, which is increasing. So the orange line is the incidence of NETs over the last few decades. This is according to American SEER data. And as you can see, it's rising compared to all cancers, all other malignant neoplasms on the blue line, which has remained virtually static over that time. And because of the rising incidence and a lengthy survival, patients can survive for many years, although some have more aggressive disease, the prevalence can be quite high. So apologies, because I think some of the formatting when it's come from a Mac to a PC is not quite worked out here. But this is a cancer that is known for its delays in diagnosis, because patients can present with vague symptoms before having imaging and biopsy, suggesting they have a neuroendocrine tumour in one of these organs or metastases. And so there's a lot of anxiety that gets built up when they eventually come to us. Next slide, please. So the natural history of a patient with a NET, it's a cancer and a chronic disease. And the tumour burden in someone who's got advanced or inoperable tumour, neuroendocrine tumour, wherever it is in the body, and or metastatic disease, can generally go up over time. There's very little in the way of treatments that can completely eradicate it apart from surgery. So this is a model of tumour burden, increasing at various times over and at various speeds and some periods of stability. And the time, the x-axis can be a decade in some cases, maybe 2 decades in some cases, an average of 7 years for some of the low-grade NETs, but can be a year or so in some aggressive NETs. And at various time points, we will give, and you don't need to know about them, the various treatments that we have on offer. There might be some debulking surgery, palliative surgery, and then palliation towards the end. Next slide, please. So this is an individual patient story. So I moved from London in 2014 as a general gastroenterologist with an expertise in NETs. And a few patients started to come to me when I arrived. In this particular case of a 61-year-old woman who had a small bowel NET with metastases. She was diagnosed 6 years previously under other teams and had been on monthly injections which is the first line treatment to try and control disease. And she had stable disease on imaging. So the scan suggested that all the metastases and the primary tumour, it wasn't growing, it was working. The treatment was working. Having said that, she had a normal colonoscopy because of some symptoms, and she asked to see me. And she had a hell of a lot of symptoms. She had a lot of GI symptoms and a high GI burden. So she said, I can't even travel on the bus to see my daughter as I open my bowels 20 times a day. And she was in tears. And she lived in one of the valleys, and her daughter lived in another valley, and it was really difficult with the connections, and she was crying. Again, the emojis haven't quite made it across from the Mac to PC, but I remember this case, and clearly her symptoms were impacting her quality of life, despite what in an oncology world would be adequate treatment to control her disease. Next slide, please. And we did, and I arranged investigations for GI symptoms, managed some of them with all sorts of things, which I'm not going into, but that is what I termed a black box, which then preceded her to be happy. And she was incredibly grateful, and that she could then travel around and her quality of life improved. Next slide. The patient charity, the UK patient charity, had for Neuroendocrine Tumour had received a number of sort of cases where positive feedback was being given. So there's clearly a change in something that was happening, and something that I term this black box of some investigation management. Next slide, please. So I started to think, and I thought about this with neuroendocrine tumours in London as well, and at the Marsden, the Royal Free, where people had stable metastatic disease. In meetings, we would be, all the multi teams would be looking at the scan and saying, oh, everything is stable. They're on the right treatment. And they've had normal biomarkers and other investigations for their cancer. But underneath, when you see the patient, there are all these things going on where symptoms which may not be directly related to the disease, may be a consequence of treatments, psychosocial consequences of what I talked about before, the diagnosis, the delayed diagnosis, and the psychosocial consequences of their symptoms and their unmet needs, all impacting quality of life. And I felt this was unaddressed. And next slide, please. So this was what was going on in my head. It was only years later that I started to put this down. And so you have the tumour burden there in the blue line, and you have the tumour treatments again in the blue boxes at various time points in the disease. But patients can develop symptoms at various times, which may or may not relate to what's going on with the actual tumour. It could relate to something else, like the tumour treatment or something else, or after having surgery. And quality of life can be impacted based on all of that and other things, such as psychological issues and the effects on mental health. Next slide, please. So started to use this tool, which is a validated tool in NET. So there's two, which is the EORTC GI-NET21, which is validated with one of my colleagues who's actually just emailed me just before this talk, in Europe, and that's a quality of life questionnaire, and also used a GI symptom scoring tool, which was used as the Marsden clinically for GI symptoms in cancer patients. And I started using this just in the clinic on paper before patients came into the room as an aid, really, to the history taking. And 80% of diagnosis in medicine is down to the history, and it just aids that history taken on an individual basis. Next slide, please. Quite soon we got some data together, and in patients who were under other teams with this existing diagnosis scattered throughout the health boards and Cardiff and Vale, there was a high burden of all these GI symptoms, and it was surprising to a certain extent. So bloating, the greasy stool is due to a side effect of the injections used for treatments, somatostatin analogs, octreotide injections. It can cause a fat malabsorption, which to us in gastroenterology is bread and butter, really mainly easily treated with pancreatic enzyme replacement therapy. Gurgling, sort of towards the right-hand side, that could be an indication of bacterial overgrowth in the small intestine, which can be tested for and treated. So high burden GI disease and PROMs we were able to use PROMs to gather this data. Next slide, please. So at the same time, WISC were lobbied as national committees in Wales by patient groups and other stakeholders. Actually, prior to when I came, but there was a task and finish group that was put together by WISC. This was a patient survey and a relatives or carer survey targeting patients across South Wales with NETs under the various different teams, and it was a bad survey. There was a lack of competence and expertise, lack of information, communication was poor, according to the patients, lack of attention to symptoms and quality of life, no specialist nurse input, or very little, and the lack of access to specialist investigations and treatments, or perceived lack of access. All in all, this was an historic fragmented service with inequalities across organisational boundaries, and this is in 2015. And the overall satisfaction score for services was around 19%, with that high burden of unaddressed gastrointestinal symptoms, which we alluded to. Next slide, please. And additionally, we teased out that the delays in diagnosis, which are known about in neuroendocrine tumours compared to other cancers throughout the world. People talk about it in the NET conferences and the NET patient conferences, and there's not much that has been done about it in terms of changing the situation and how to improve delays in diagnosis. But the patient surveys and the literature would suggest the symptom onset to diagnosis time of, can be years, as you can see, and a high rate of metastases at diagnosis, but that was mixed populations, and those bullet points are from patient surveys across the world rather than hospital data. So this graph shows one of the questions from that patient survey in South Wales on the previous slide. Before your NET diagnosis, what were you being treated for? And the vast majority would say IBS, irritable bowel syndrome, which shares common vague symptoms in the gut, similar to NET, and also Crohn's as well. And that's commonplace throughout the world. Next slide, please. And then, sorry, previous slides. No hospital data on improving diagnosis times. Next slide. So this was the health, well, obviously the slight adjustment, but the health boards in Wales, and the docs representing some of the hospitals. And had to work together to try. All the referrals will come from all these hospitals, and the WISC were the people that had to try and improve things together with the clinicians, writers, and managers across South Wales. Next clip, please. And with that came data, and quite soon I realised that I knew this from times in London, that the diagnosing clinicians in secondary care would be gastroenterologists and surgeons, and those were the groups of specialties that would focus on for the front end of the service. Next slide, please. So the Pass and Finish group was put together by WISC as our national commissioners, including patient groups, representatives and clinicians, etc., managers. And there were service models put together and appraised by patients, carers, commissioners and international experts. And a limited hub and spoke model was agreed on, which was gastroenterology-led by myself across the 7 health boards and trusts, with involvement from oncology in Bilindra and South West Oncology Centre in Singleton. And regular stakeholders meetings occurred also during implementation, so patients were really involved. Next slide, please. So a whole host of things, I can't go into the detail that we did. The multidisciplinary team meetings were improved in terms of frequency, in terms of staffing, the expertise that were required, that was missing, which existed, they just had to be brought in, planned. The engagement process with the clinicians that were diagnosing or suspecting next in all of those hospitals, and forming relationships with them, live data capture, using prompt clinical feedback, and all sorts of things. So we've received actually now 800 new referrals and approximately 300 pre-existing prior to that. Next slide, please. Next slide. Next slide. So the grey box on the left, we realised, and I know there's a tertiary versus secondary care pendulum, and I know that patients do not really want to travel to Cardiff unless it's absolutely necessary. So there's certain things in local hospitals and health boards that we could coordinate with guidance, and including imaging, pathology, psychology services which are in existence, dietetics, etc., endoscopy, simple endoscopy. But what we added was quite a lot of the tertiary support, and actually the tertiary clinics, which I'll come on to, and the referring team engagement, team communication, their specialists that we recruited, trained up from scratch, who are crucial now, and PROMs. So we use PROMs on paper in quite a large portion of the patients coming through, as well as patient engagement education. Next slide, please. So training and education was really important as well, and we aimed it at the gastroenterologists and surgeons primarily who are making diagnosis, but also all the other involved specialities throughout Wales, endocrinology, oncology, palliative care, etc. Next slide, please. And it's a complex model because everyone, as I said, every case is different, and different primary tumours, different metastases, different speeds of growth, etc. But between us, we have the bulk of the patients in our gastro-led clinic in Cardiff, the oncology requirements both in South East and South West, and endocrine net clinics for some interesting rarities as well, and syndromes. And we, in the top right, we utilise PROMs. We repeated patient experience and looked at symptom onset time. And we also needed other peripheral specialities which were commissioned centrally or locally, as and when required. Next slide, please. Okay, so this just shows the flow of the patients from 2017, which is when late 2017, when we transformed things, with a lot of local follow-up with help and guidance, and also gastro-led central clinic and the other specialties when required. Next slide, please. Next slide. So the diagnosis, so the median time of diagnosis halved, and we didn't aim to do this. This was a byproduct really of producing the model and the engagement and the education. So this is the midgut, so the small intestine method with population, which is the most difficult to diagnosis, and that diagnosis halved. Statistically significant, and the proportion of patients diagnosed with metastases also reduced. Next slide, please. And patient experience also improved, as well as this was on the repeat patient survey, access to information, and to CNS. And satisfaction went from 18 to over 90%. Next slide, please. So let's listen to the patients if this video works.
Isolated, alone. I thought I was the only person in the world who had this.
I wasn't told what sort of cancer I had.
A downhill slope to my death, basically, because nobody explained anything whatsoever.
I was told nothing, and when I went home, I thought I was possibly going to die.
I feel cared for, I feel supported, I have plenty of information.
My life has changed.
I had that first appointment with Dr. Khan, and he sat me down and explained what neuroendocrine cancer was.
I think the support has changed insofar as I've got two good contacts in Landoc and a consultant who I know is easily accessible if we need him.
I know that I have the two nurses, and I have Dr. Khan, and I can phone at any time and they'll give me any support that I need.
Pardon? What service?
No support whatsoever.
Inadequate all round.
Brilliant. Absolutely brilliant. 3 words.
A whole new world.
Absolutely excellent. Couldn't ask for more.
Next slide. So thanks to the patient groups. So we utilize PROMs, and as I mentioned, and this is just an example of visualization done by Russ White, and I'll acknowledge them, and Nav got acknowledge them at the end. But this is an example of what can be done based on a particular collection of PROMs analysed by tumour type, and those tumour types from the different parts of the body on the left that I talked about at the top. And you can look at various symptom scores and quality of life scores from those, which can give an overall sort of service level sort of secondary use type of analysis. Next slide, please. But we looked at the PROMs collection paper before and after the transformation, and it's difficult to sort of, present, but you can see that there are more green on the right-hand side than on the left-hand side, which indicates better scores post-transformation. Next slide, please. And statistically, that there is, in terms of total symptom scores and total quality of life scores, there's a statistically significant improvement, and 94% of the patient survey felt their symptoms had been addressed. So this is an example of from improvement being demonstrated in a service through co-production. Next slide, please. And if we go back to those models then that I talked about for this disease, then in an ideal scenario, we would want PROMs at various time points. And I don't know whether Amanda is watching, but we've had many a discussion about those specific time points. So this is a sort of model that would be working towards for individual patients. Next slide, please. And examples of more visualization. So we had these PROMs in a surgery project. So surgery is strange in NETs because sometimes, even if there's lots of metastatic disease from the small bowel, then surgery can be indicated to remove the primary to prevent future complications if the patient is surviving many years. But the data around that in clinical trials is, well, there's no prospective clinical trials in the whole world. And there's always retrospective data, and there are disagreements in the community. So we can actually see we've yet to do this analysis, but you can see that there are certain scores that patients can have, which may be a consequence of having surgery or not having surgery in a metastatic setting. Next slide, please. And another way the visualizations which Russ helped us with and conducted is within this, you can actually look at people who've had elective surgery versus emergency surgery for their small bowel net. And you can see there may be trends. So the top half of the slide is one tool, symptom tool, and the bottom half is the quality of life tool. And you can see that there may be better patient outcomes with elective versus emergency surgery, although there's lots of retrospective and with a caveat of a degree of bias. But it's an example where PROMs, if used prospectively, could be utilised to answer important clinical questions. Next slide, please. And similarly, as I said, we can, our surgeons, if they've got a small bowel net and lots of metastases, can leave this thing in the mesentery in the abdomen, which can cause a lot of scarring. They can leave it in situ or completely resect it, or they may incomplete resect it. And you can see there's a trend according to whether that's been the case. And this is Russ again, who's helped us with this visualization. Next slide, please. And again, as an example of how things could be used, these are scores in the higher categories, so quite a bit or very much on an ordinal scale. And the top half is the elective surgery, the bottom half emergency surgery, and you can see that there's a more burden of symptoms and quality of life. And you can actually look at the individual question burden as well, compared between the groups. Next slide, please. And this is interesting. This is the psychology form that we use, which was actually part of our work with our psychiatry team and psych liaison team and psychologists, and using PHQ for anxiety, DHAD for depression, and emotional thermometers. You can see that on the top half, you've got various primary sites of NET and higher burden of psychological morbidity in some rather than others. And the bottom half of the slide is the phase of the disease. So looking at the phase of that chronic cancer disease from the first diagnosis, phase 1, right through to terminal phase, phase 6, and stable disease being phase 3. You can see that there is a lower burden of the psychologically, the anxiety and depression and emotions at when they have got stable disease. So and it rises when there's progression. So it makes sense, but it's an example of how psychology and mental health can also be tracked alongside physical disease. Next slide, please. So in summary, this is partnership working to improve diagnosis times in NET. PROMs provide an opportunity to improve individual patients' care, and overall, at a service level, there's significantly improved patient-reported outcomes, quality of life, and patient experience on the South Wales level. So PROMs can provide an opportunity for health outcomes research and service redesign. I've given you examples, and this is demonstrating a successful co-production because this was all done together with the patients and the representatives. And it was transformation with genuine engagement with patients and clinicians. Next slide, please. I'd like to acknowledge the whole team, whole NET team across Cardiff and from the with Linda and students who helped some of these projects, as well as our patient representatives and stakeholders. Next slide, please. And Nigel and Russ from the Family Health team have been really supportive, and Russ did a lot of work on some of the graphs in the second half of the presentation. So thank you. And next slide, please. Our external partners, the Royal Free Liverpool, our national charities, obviously Valiant Health, and other people that have supported us along the way. Next slide, please. And I'll leave you with this quote. Okay, thank you.
So Mohid, we've had a couple of questions come in whilst you've been speaking. The first of all is, in a chronic condition which presumably has multiple interventions, how do you approach timing of PROMs to balance meaningful data related to interventions, but without burdening patients? Do you reset the clock after each intervention?
Yeah, I'd say that what I presented is actually just the beginning of the story, really, although there's been a lot of speed. I think COVID has changed things. So when everyone was coming to clinic, everyone was waiting outside in the waiting room. It was an aid to the clinical consultation. And we're always mindful. I've always been mindful, actually, back in research days in London, of burdening patients with questionnaires. And personally, as a patient in a couple of services, I've completed a lot of questions. So I'm very mindful of that. I think you have to have a balance. You have to have the correct selection of tools and the correct timing. And then this is not just one disease, although it's NET, it's so heterogeneous. It may be easier in a particular chronic disease, which is more homogeneous. But with NET, we'd have to be finding our way, what type, what grade, if they've got aggressive disease, don't want to burden them too much, is actually going to be helpful or not. We do have some data that hopefully would work with CEDA to actually analyse how often it would make a difference to measure in terms of frequency. And do we reset the clock after each intervention? I think it's, in terms of interventions in NETs, there may not actually be, I might have maybe not, without talking about NETs in great detail, it's difficult. The interventions aren't, there's quite a few interventions right at the start. You may have one or two interventions during a period of several years. Would we reset the clock after each intervention in terms of PROMs? I think it's important to see how things track over time, really, in that particular patient. Hopefully that answers the question.
Thanks, Mohid. And the next one, not quite a question, but just an acknowledgement from Amanda saying, yes, Mohid, the relevant time points for collection without overburden to patients or services are always a hot topic of conversation. And another question, how do you select the tools you use, and do you ever add or remove tools to personalise the collection to a patient's needs?
So first, how do you select the tools? So I guess we're in a sort of tertiary service, which is and we're in a uncommon disease where there's not much there. There's hardly anything there, and so there is one EORTC quality of life tool. There is one other thing that there's another tool that maybe 2 centres have used, and that's it. So it's not, because it's uncommon, it's not rare anymore. The prevalence is actually the second most prevalent gut cancer, second to bowel cancer. But because it's uncommon, we don't have a lot of tools out there, so that becomes more simple. I think there are obviously there's been other talks on selection of tools and what tools to use. In terms of these particular nets, and what we did was that there's a quality of life tool which is validated, so we use that. It's used in studies, and it's also been mandated to become a European Centre of Excellence. So that's what we have to do, and we're working towards that hopefully in February. The symptom tools are based on actually what the patients thought. So this was co-productions. The patients, we talked to the patients, and they were reporting lots of gut symptoms, and so we chose a GI symptom questionnaire, which has been used in other cancers. The second part of the question was, what was it? Sorry, it was just repeat the second part.
Do you ever add or remove tools to personalise the collection to the patient's needs?
Yeah, I mean, obviously this is not digital right at the moment, and hopefully will be soon. Do we? I think it's important to ensure that, depending on, well, I think there may be some work that needs to be done on using the right tools for certain patients. If it's not going to make any difference whatsoever, and without explaining all of nets, there are a couple of different types of nets, which actually to use a PROM would probably cause more anxiety, because there are really simple. There are simple cases, an appendix net, which is fine incidentally, doesn't require follow-up at all, and so you'd possibly not choose a number of tools for that particular patient. I think we do add and take away, but some of it is hopefully going to be made easier once we have a digital solution.
Thank you. And this question you've partly answered, but I'll read it all out to you, and you can choose the bits. Do all patients complete PROMs at the same time on their pathway, and how did you choose the particular PROMs tools, and are they commonly used elsewhere in the UK?
Okay, so what was the first part? Because I've answered the
Do all patients complete PROMs at the same time on their pathway?
Yeah, so in the service redesign, patients were coming in to the service from an old service, so we effectively measured everyone. We did that as a baseline. For new patients, when they're diagnosed, when they're coming to us, we will, as soon as they're diagnosed, we'll measure that. We will do that as baseline. So yes, they're at the same time. In terms of repeated PROMs over the course of their disease, that's something which has been difficult, been made more difficult by COVID. And pre-COVID, they were generally doing it every 6 months, so at the same sort of time course. We would want to tailor that with a digital solution and according to type of net. So I'd say, answering the question, partially yes, but hopefully that will become more optimal as we move forwards. I've already answered the question about selection of tools. The GINet 21 tool is used in not just the UK, it's used in the whole world, Europe particularly. We've got the European Net Society, which credits centres across Europe and actually in the States and Australia at the moment. But this is mandated, so the centres are generally using that particular tool. The other tool, symptom tool, has been used quite extensively in the post-radiotherapy and cancer population in assessing gut symptoms. Yeah.
And one last question from those we have at the moment. There are many other chronic conditions in gastroenterology. How is adoption of PROMs going for patients with those conditions?
Yeah, so I'd say I can't speak on behalf of all of gastroenterology, although I'm speaking to the British Society of Gastroenterology tomorrow. But I'm going to speak wider than Wales. So in inflammatory bowel disease, which is the most common condition in gastroenterology, there are a number of PROMs that have been used in research studies over the last decade. Clinically, some centres have started to use those PROMs in clinical setting. Certainly some of the large London centres and Birmingham, digital solutions as well. It's a bit of a hotspot, but some centres are doing that. Actually, the person in Luton, one of my colleagues, former colleagues, that has actually been using PROMs for a very long time digitally. In terms of the other conditions, I think they are, in terms of nutrition, there's a little bit of work done in, I think, Salford, St Mark's, and I'm not sure about celiac disease. So there are, some other chronic conditions. Those are the most common chronic conditions. So they're at various stages, and I'd say IBD particularly is moving rapidly. In Wales, there's certainly IBD that's been IBD PROMs that have been recorded infusion treatment, and that's manual paper PROMs or PDF PROMs, and that's being analysed currently, I believe. So there are other gastroenterology PROMs work going on throughout the UK. I'd say this is falls in gastroenterology and cancer. So this is actually with NET, it's a mixture of cancer and gastroenterology and endocrinology. So and obviously there is a fair amount of quality of life and PROM work in cancer, although this disease actually is a mixture of both, which is almost a unique model.
That's lovely, thank you. And that is the last of the questions that we've had through for you today. So I'd like to say thank you so much for what's been a really interesting talk.
Okay, well, thank you very much.